So, afternoon, everybody. So my voice is probably sounding a bit wobbly because I'm really, really nervous. I'm a person who lives kind of with a high degree of anxiety in their life. So, and sometimes my coping strategies work, and sometimes they don't. So yeah, even a normal day for me involves a fair amount of anxiety, as Adrian would probably tell you after kind of been working with for a long time. So yesterday he caught me making little patterns out of the wrappers from the sweets on the table. Just a bit embarrassing, really, but anyway. I'm going to start off with telling you a little bit of a story, and this is more for my benefit than it is for yours, really. But this is to kind of, this is kind of setting the scene, really. So some of you know already, who know me well. I have a 28-year-old son who has Asperger's syndrome. He lives in Berlin, and he earns an absolute shitload of money as a software developer. He's married. I've just been to stay with him. Bearing in mind he's been living in Berlin for almost 2 years. We got there, brand new apartment, luxury complex. Their apartment is, him and his wife's apartment is almost completely empty. They didn't have a kettle or a toaster, for example. They've lived there almost 2 years. Their entire furniture consists of a table and 2 benches. That's it, and a bed. Oh, in fact, they don't even have a bed, they have a mattress on the floor. So, this is a young man now, pushing 30. He's got an IQ almost as high as you can measure, but he can't buy a kettle and a toaster. Because he looked at the specification of every single kettle and every single toaster that was available and got decision paralysis. Couldn't figure it out, which was the best option. So, I thought there's 2 options here. I can spend a long time kind of working through problem solving with him, or I can go down to Muji and buy him a kettle and a toaster, which is what I did eventually, because I thought, it's really not worth it. The kind of point to that story is really kind of, my research involves people with autism with and without intellectual disabilities. But the group without intellectual disabilities can still have significant disabilities, and it shouldn't be discounted. And that's a kind of part of my research really was about looking at what's the effect of autism, what's the effects of mental illness on people, and what's the kind of the cumulative effect of both, living with both challenges in your life. So to give you kind of a bit of background to my presentation and how I kind of framed it, we're in a time when we've got multiple drivers of change happening in disability services. We've got human rights principles and legislation underpinning the way we work, making sure that people are not discriminated against, have rights to have choice and control. We've got human services values that have grown out of activism, that have grown out of the work of people like the O'Briens, Wolf Wolfensberger, etc. I lived and breathed kind of work of John O'Brien for a long time. It's still very dear to my heart, and it was great to hear Sarah talking about it in her presentation as well. We've got a depth of research now. Not as much in New Zealand as I'd really like us to see. And obviously, you can tell I'm not from New Zealand originally. I'm from Yorkshire, but I've been here a long time. I've worked in New Zealand longer than I ever worked in the UK. We've got systems transformation happening, shaping how support services are going to be provided for disabled people, with the intent of increasing choice, control, autonomy. And this has been developed using a co-design process with disabled people at the core of the process, which is brilliant, absolutely brilliant. So far so good. But I've spent a lot of time thinking about those people with really complex challenges in their life. What happens for those people whose needs cross the boundary of disability and mental health services, and primary and tertiary specialist and specialist health services as well? Because as we know, as well as mental health comorbidities, there's a lot of physical health comorbidities in our population. I've also been thinking a lot about what the place for evidence-based practice is in all this. I mean, I've Explorer here in force, and I've done 6 or 7 presentations, I think. And it's a kind of shining light in terms of evidence-based practice. There's been great presentations from DHBs, but what I'm not seeing is that kind of in disability policy. And thinking about the kind of position of evidence-based practice, and I almost felt like it's been kind of sidelined a little bit, maybe even given a red card and sent off in some areas. Maybe I'm wrong, I don't know, but that's kind of been my perception, that we've focused a heap of work on the kind of rights and values based, which is absolutely as it should be. I'm not criticising that. But there is a whole other side to this, which is about science and how that helps us to make good decisions and provide great support for people. So in terms of my kind of interest in this, why am I getting kind of hot under the collar about it? I spent the first part of my career helping people get out of institutions. I worked in the UK. I worked in that first wave of positive behaviour support, late 80s, early 90s, getting people out of institutions, working with people like David and Toby Brandon, people coming and talking about, living the service values, this is how I worked in the first part of my career. Not that those things have gone away, but other things have become the focus as I've kind of had different jobs. But I also trained in applied behaviour analysis, and that works from a set of scientific principles, which my old friend Oliver Mudford would say were value free, but I don't believe anything's value free. And as we know, kind of in the way we're working now, we've got applied behaviour analysis and values kind of equals positive behaviour support to some extent, if you want to kind of frame it that way. As I said, I'm a dad of an adult son with Asperger's syndrome. He's had more than his fair share of mental health and neurological challenges in his lifetime, including getting excluded from 3 schools, having episodes of being suicidal, having episodes where he couldn't kind of get out of bed and face the world despite a huge amount of support. And I've seen really great examples of evidence-based practice. We've used some of it as a family, but I've seen some really bad practice of people working based on opinions that they'd formed about Jake. I've spent a chunk of time working with people under the IDCCR Act who've had their rights taken away from them, and sometimes for very good reason, because they've been doing things that were not acceptable to society. But sometimes, I've thought about, is this the right thing to do? Just as Judge Beecroft was talking about this morning, kind of challenging that status quo. We've got an approach that's about containment, the rehab kind of part. I've seen great presentations this time about kind of some of the rehab work that's going on. I think there's been a dearth of that work previously. I've also spent a significant part of my life supporting people who have severe mental illness in addition to their intellectual disability and autism. So when I first came to New Zealand, I worked for Otago DHB, initially in the secure service and then as manager of the ID service, including a really good specialist dual diagnosis service, which has gradually got diluted over the years. So, to our presentation today, and a bit about my research. Back when I was working with Adrian at Community Care Trust, I had this idea to do some research looking at the mental health of adults with Asperger's syndrome. Adrian and I were kind of basically running I guess call it a counselling service. I don't know if that was really what we were doing, Adrian, but we were trying to do something useful for some people. And between us, we were seeing about 12 people on a weekly or fortnightly basis. We're using a combination of CBT with a dash of narrative therapy and a bit of ABA, and we were kind of making it up as we went along. Really? Yeah. It was kind of one of the most enjoyable parts of my career, really. It was a great piece of work, and I think we made a huge difference to some people. So I had this idea that I was going to look at this kind of treatment model and whether we could kind of publish it and come up with something out of it. But then I changed my job and kind of got, it went in a different direction. Somebody approached me to go do something different for another organisation, Sharon Branford. And I'd already enrolled in university at that point, and I started developing this idea of a research project. And it was going to be really small scale, looking at treatment outcomes. And then I kind of started working with a whole bunch of people who've got really severe intellectual disabilities and severe autism. And that kind of took me in a different direction. So I started thinking about what could we do for this group of people in terms of understanding their mental well-being, mental illness in this population. What's going to work in terms of treatment? What's out there that's evidence-based interventions? Surrey yesterday kind of gave an overview of the kind of research around mental illness and interventions in this most significantly intellectually disabled group, and there's very little out there. Those of you who've looked will probably know that very well. I've presented on that before, but I still kind of had this in my mind that I needed to expand my research design and think about that group and look at what could we do. So I came up with this idea about doing a bigger study looking at the mental health of people with autism. But then I also thought, well, who am I going to compare them with? Can I find a general population group and look at whether there's similarities and differences, or would it be better to have a group of people with intellectual disability? So what we ended up doing was a 3-group study, and I'm going to talk a little bit about the kind of the groups and who made them up and what we actually did. So, being the madly over-optimistic person I am, I enrolled in a PhD despite the fact that I was working full-time. My advice would be, if you ever have that idea, discount it. Because 7 years later, I was still at it. And my own mental health was terrible by the end. So I'm going to use my kind of research to talk about how science supports values and vice versa. I am going to use some kind of technical language and use to some extent the language of psychiatry, because I did my research very much in a psychological medicine paradigm. That was my research area, and that was where my supervision was coming from. And I'm going to talk a little bit about this later on, but I got really interested in the neurobiology of autism and of mental illness, which I'm going to kind of touch on and talk about things like brain structure. And I know some people might say this is a very medical model. I just want to be right up front and say, this is not about fixing people. This is not about objectifying people. This is about using the best of science to improve people's quality of life. So to me, it absolutely fits in with our values, with the rights-based approach, with the kind of, if you want to call it scientist-practitioner model. It fits with the way that we design services. One thing, anybody recognise where my title came from? Apart from Patsy Frawley. Nigel. Billy Bragg, brilliant. I haven't got a spot prize, sorry Nigel. I did think about having one, then I forgot about it. But my other life as a musician, and one of the things I do, and some of my IHC colleagues will know this very. I have theme songs that go with different bits of my life. I'm a bit weird, so you'll have to excuse me. So this idea of science and values clashing, I mean, I've heard this debate going on for 20 years now. That's not social model. This is medical model. Blah blah. And I almost think we're at a point where it's a null argument. We have a very well embedded social model of disability. We're not doing things to people without their consent. Well, we shouldn't be. Hopefully we're not. There is some great science out there that could be very much applied in settings, in context, to support the work that we're doing in terms of giving people great lives. And I want to talk a little bit about some of that, particularly from the neurobiology side, because it's really changed the way I kind of think about things. I had this slide in here originally that said autism is a result, not a cause. I took it out and I thought, what I was kind of getting at is the fact that autism is a behaviourally defined condition. There is no clear marker for it, really. We've decided what it is. A group of very elderly American psychiatrists have come up with what it is, to be quite honest. And those of you who know Justin Barry Walsh, I heard Justin making very negative comments about this, saying, why the F should American psychiatrists decide what is and isn't a diagnosis, which I thought was quite interesting. So part of my journey has been thinking about kind of diagnosis and what it means and what the usefulness of it is. I'm going to come back to that at the end. Okay, so I'm going to start off with a quote from one of the guys who was involved in the study. Some of you might have seen this before, because I think some of you've seen me present a bit of this kind of research before. So Mr. G. So I want you to read this, but I'm going to emphasise a couple of points. So this is part of my qualitative part of my research. So I really wanted to find out what people's experiences of having both autism and a mental illness were like. what it was like for them. I didn't want to just know how much, how severe. I am very naturally, very quantitatively oriented. I like numbers, I like stats. But actually, this was the most fun part, talking to real people. And some of these guys I've known for 15 years who are part of the sample population. I don't know whether this is working quite right. But
You need to look at the bigger screen, I think.
yeah, okay. So that line there, I can see it now. I forgot about this monitor here. So trust me, I don't make a habit of it. I only go when I need to. What does that say about Mr. G's experience of using emergency mental health services? Wasn't that great, was it? What do you think's been said to him? It's just behavioural, it's not mental illness, that's the usual one. So what else do you think might have? Omega, yeah. What are you coming here for? Yeah. The second part I want you to really think about is this bit down here. I don't know if there's anybody left from the ministry, but this is the bit. Okay. So this is Mr. G talking. So he's talking about when he goes to emergency mental health services and what happens for him. So they've just talked over with me and with my support workers, like straight. And it's like, you know, they try and piece the puzzle together and take, why are you feeling like this? And how they can fix things to see if they can put your staff hours up or something, you know, support hours up and stuff. But then EPS can't do that automatically because it's got to go through the funding organisation. It's got to go through the funding organisation. So this is, I think, it's so poignant for me because here's a man who knows his mental health is not good at times. He makes use of all kinds of services. He's one of the most incredibly anxious people I've ever met in my life. But he's so insightful here because he's saying, you know, I get most of my mental health support from my disability support workers, basically. I'm getting very little for mental health. The one thing they could do when I go to emergency psych services, actually, if they don't need to admit me, is give me some more support. But they can't do that because that's a different NASC. So this is a real challenge for us. You know, as we move into the new individualised funding kind of model around disability, what do we do when people have dual needs of both intellectual disability or autism and mental illness? Who's going to fund this? Mr. G's saying nobody can do it unless, you know, I go and have another needs assessment. Not particularly helpful. I mean, if there was some way of having a flexible package that can be up or down depending on what his mental health is like, could be great for him. And actually, the organisation that supports him do that, but they don't get any money for it. Okay. So these are some key points to kind of get you thinking about why I kind of embarked on this, and I'll tell you a little bit about the results in a minute. But just some key points that came out of my lit review when I started the project, and I don't think there's anything any different now, honestly. 25% of adults with intellectual disability also have autism, roughly. It's as close as we can get in terms, because not everybody's had an assessment. But in terms of what the evidence says at the moment, most adults with autism have poor outcomes in adult life, poor quality of life, difficulties with employment, poverty, poor living situation, difficulties with relationships, multiple mental health problems compounded by difficulty with access to services. If you happen to have autism and an intellectual disability, it's worse still. Not very cheery, I know. And I tried really hard not to make this deficit focused, this research, but it was really hard to not make it deficit focused. At the end, I'm going to talk a little bit about kind of some things I think would actually work. But what I found really, in terms of my original lit review, was pretty depressing. So adults, especially adults with intellectual disability plus autism, take more psychotropic medications than any other group. If you want references for this stuff, I'm happy to kind of share them at the end. Or email you. You can read my thesis if you like, it's all in there. It's not very exciting. It's a very long read. I have met 2 people who've read it though. Yeah, thank you, Fran. Adults with ID plus autism, internationally, the highest users of specialist behaviour services. Probably not a surprise to anybody, really. And the most likely to be subject to restrictive practices. It's usually me, don't worry. Adults with intellectual disability plus autism are the least likely group to live independently, and they're not well understood by mainstream mental health services. So some bits of the world have got specialist mental health services for people with autism, some bits of the world have got specialist mental health services for people with intellectual disability who also see people with autism. Changing funding is not going to change any of this, so it doesn't matter really who's paying or what we're paying for. Those factors are still going to exist. It's not a reason not to change. There's lots of great factors driving change, but it's not actually going to change any of this for people. So in terms of what the evidence base says at the moment, most ASD research is about children. 2/3 of it, really. There's a good collection of studies by Patricia Howlin, Steve Moss, a number of other people who've looked at adult outcomes. 2009 study is really good. There's a follow-up 2012 study looking at the impact of having both autism and mental illness, and that kind of double, that dual diagnosis having really significant issues in terms of outcomes as an adult. There is a growing literature around mental health problems in adults with autism, but it's still kind of at a very experimental stage. It's still often using clinic populations, not community-based populations, so it's not terribly reliable. So that was another one of my drivers, really, was kind of thinking about, how useful is this research when we're only looking at populations that are already accessing mental health services? What about all those people who are not accessing mental health services? But just to kind of give you a summary, what the evidence is currently saying, about 30% of people with autism spectrum disorders have a comorbid anxiety disorder. There's a community prevalence study that suggests, I think that was White, about 2006, where they found about 13.6 in a community population in Australia. And it was quite a big sample, but most of the clinic study populations are saying about 30%. There's also that question, and people have asked me this time and time again, and I've asked it of other people who know far more than me. How do you tell the difference between autism and anxiety? And I will come back to that in the stuff I'm going to talk about in terms of a service model. Sorry, mood disorders, major depressive episode, clinic populations, 30 to 50% of people with autism who are turning up at mental health services are presenting with depression. That's bloody high, isn't it? Yeah. Yeah. There's some interesting studies by Joshi looking at bipolar disorder in people with autism, which is showing there appears to be some kind of link, maybe genetically, with episodes of mania and autism. It's not conclusive, but it's kind of saying there is a higher incidence of bipolar disorder in people with autism. And I've certainly worked with a number of people over the years who are on some fairly substantial medication for bipolar disorder and have autism. Schizophrenia is really interesting when you think that autism grew out of being a diagnosis of childhood schizophrenia. The actual incidence of schizophrenia in people with autism is really low, 0.4 to 0.6%, but the worrying thing is the incidence of catatonia is really high. So people not from a mental health background, catatonia is kind of a state of kind of reduced behaviour, motivation, can involve things like kind of freezing in particular postures, not being responsive to external stimuli. And 12 to 17% in terms of catatonia is very, very, very high. It's like about 40 times the general population or something. But there's a very small number of studies that have looked at that. The one that's getting a lot of attention at the moment is ADHD, and attentional and concentration problems. But most of the studies are in children and adolescents. But I did look at this in my study with adults, which I'll talk about in a minute. Norbert Sakauskas has done quite a few studies looking at prevalence of ADHD in kids with autism and finding really high rates, sort of 40, 43%. So this is kind of what I set out to do. It was a bit grandiose, honestly, and overly optimistic, but So I was living in Dunedin at the time, so this study is entirely based in Otago, Southland. Well, I was living there when I started, should I say. So I set out to look at, what's the range of psychiatric disorders experienced by adults with autism, looking at the differences and similarities between those with and without intellectual disability or intellectual disability only, trying to find out what effective treatment strategies and support strategies were, and to identify service gaps and future needs. I'm not sure that I didn't achieve 100% in any of those. I think I got some stuff that is useful and can help us. So this is the people. 68 people, 31 with both intellectual disability and autism, 15 with autism, no intellectual disability, 22 with intellectual disability without ASD. So my grand plan was to have 30 in each group, but recruitment if you think about Otago, Southland, I worked out there would be plenty of, based on prevalence data, as best I knew, there should be plenty of people. But actually finding people with autism without intellectual disabilities who are not engaged with services is quite hard. And I used my kind of networks. I used three different service providers to help find people. I used the local Autism New Zealand group, Altogether Autism Contacts, my own kind of personal contacts, my son's friends. But I ended up with a group of 15. And statistically, it worked okay. It would have been more powerful if I'd had more, but yeah, worked okay. So this is a study design. It's a 6 component studies that make up the whole kind of research. So the systematic review of pharmacology in autism, a systematic review of psychological treatments, the major quantitative piece, which is about psychiatric screening of the entire population of all 3 groups. I did some work on the psychometric properties of the tools, which was fascinating because I'd never really done psychometrics before to that extent. I kind of, it was something I knew about but didn't really kind of know how to do. A quantitative piece looking at the analysis of the complex needs group, and I'm going to talk a little bit more about that group because that's where I ended up kind of focusing a lot of attention really. And I called them a complex needs group because I couldn't think of what else to call them, to be honest. Any label becomes pejorative if you keep using it. It could develop negative consequences. Complex needs seems to have kind of almost done that now in the same way that challenging behaviour has, so I don't know. I couldn't think of a better name. I'm not very creative with words. The most fun bit was doing 10 face-to-face interviews, and I've peppered bits and pieces from the interviews throughout the kind of presentation. So what did I actually do? So in the major quantitative part of the study, I did three processes for everybody who was involved. I used the DCLD protocol, file review protocol, which is actually designed for doing case reviews, but it worked really well as a research tool as well, because it collects demographic data, diagnosis, living situation, current treatment. So I did that for everybody. We used 2 psychiatric screening tools that are specifically designed for either people with autism or people with intellectual disabilities. So the Rescreen for Maladaptive Behaviour, which is quite a horrible title, but quite a good tool. And a relatively new tool, the ASDA Autism Spectrum Disorder Battery. When I say relatively new, compared to the Reese, it's relatively new. Am I too quiet, Sharon? Thank you. Go. Okay. So in terms of I'd never done qualitative research before. I'd done some kind of satisfaction survey kind of things, but this was a whole different ball game, kind of learning all about qualitative research methodology. I wanted to talk a little bit about this because it's, we're talking about research to practice. So, learning how to do good research is was a big thing for me. I'd very much been a practitioner. I'd been a reader of research and thought I was relatively knowledgeable until I started actually trying to do it, which was a different thing entirely. So this piece of the research, Bridget Murphy-Veitch was one of my supervisors. And this is Bridget's, area of expertise really. So she helped me with my study design, and with the questionnaire development, and with how to kind of use thematic analysis and transcribe interviews, etc. It was a really fun thing to do, and the guys who took part in it were incredibly insightful about their own mental health. We often talk about people with autism spectrum disorders not having great insight. I didn't find that to be the case, honestly. These guys were amazing in terms of what they were able to tell me about their lives, the experiences they'd had, their own mental health, how they understood their mental health. So just to give you an idea about what these screening tools do, in case anybody feels like using one of them, or maybe you already do. So the ASD assessment battery there's a diagnostic scale which looks at autism symptoms. There's a comorbidity assessment that looks at depression, anxiety, ADHD, kind of conduct disorder type issues, and behavioural excess. And one of the reasons the authors looked at conduct problems in this tool was that they felt like some of those things that get diagnosed in childhood as conduct disorder in this population may be carried on into adulthood because of developmental delay. I'm not sure about that argument, but actually it turned out to be useful. So, and then there's a behaviour problems assessment that looks at ritualistic behaviours, self-injurious behaviours, and other challenging behaviours. I honestly didn't use the results from that in my research eventually. I didn't find it that useful. It didn't tell me anything I didn't know already. Could be useful if you were doing a quick checklist, but beyond that I didn't find it particularly helpful. The Reese screen gives you subscales for aggressive behaviour, paranoia, psychosis, behavioural and physical symptoms of depression. So it splits it, the depression symptoms, which the ASDA doesn't do. And it also looks at these personality traits of avoidant and dependent. That turned out to be quite, although I wasn't kind of thinking about personality disorder and it's not an area I was kind of looking at in my research, those actual scales became quite useful. So I don't know whether some of you might be familiar with these old terms that were used in autism about people who are anxious and avoidant or active but odd. You don't hear them used anymore, but actually these scales kind of picked out those people who are really anxious and avoidant, who kind of, the group of people who kind of might be at the back of the room, kind of standing with their back against the wall. They scored really highly on this kind of avoidance scale, which is not really surprising because it was looking at those kind of behaviours. Okay, so one of the questions people have asked me is, did they really have autism? So we've got a publication that's going to be in the Advances in Mental Health and Intellectual Disability journal fairly soon. Myself and Bridget and Elliot Bell from PsychMed in Wellington. So I use the ASDA score to basically check that, because a lot of these guys have been diagnosed a long time ago. Make sure that that diagnosis kind of still stacked up for them. So this is the score on the ASD diagnostic scales. So did the guys in the autism spectrum groups have autism? Yes, they did. The autism plus intellectual disability group. So for those of you, if you've not used these kind of plots before, box and whisker plots, the yellow box is where the majority of the scores are for that group. The thick black line going horizontally is the mean score, and the thin vertical line and the top and bottom markers are the range of scores for the group. So the people with autism and intellectual disability very tightly kind of grouped together in terms of they were mostly people with very severe intellectual disability and severe autism. The intellectual disability only group, you can see there's at least one person there who's scoring up in the autism range. So I had a false positive, which you sometimes get. He was a young man with an acquired brain injury after he already had an intellectual disability. He had a frontal lobe injury. So he scored quite highly on autism symptoms, but he didn't meet the criteria for autism diagnosis because it didn't happen in his developmental period. So we would kind of treat him as if he had autism, even though he didn't meet the diagnostic criteria, really. Kind of makes you wonder about diagnostic criteria about developmental period and usefulness of it. But it's behaviourally defined, as I said. And I called Asperger's syndrome high functioning autism group more for the purposes of differentiation, so I know which group I was talking about, honestly. Otherwise, I was getting very confused about group A, B, and C. Who, again, were relatively tightly clustered at the kind of milder end of the autism symptom range. But I've kept them there. As I said earlier, it's not about kind of their level of autism symptoms. They were quite significantly disabled. Okay. Sorry. So, in terms of some of the results, this is the kind of results from the mental health screening stuff. There were differences between groups. Sorry, just get to my notes. Getting slightly out of control here. If anybody's really interested in all the stats that are behind this, I can talk about those, but I thought it would be really boring if I talked about them up here, and so I didn't. But there were differences between groups that were statistically significant. The group with autism and intellectual disability scored higher on everything, basically. More likely to have multiple conditions, more likely to have high levels of challenging behaviours. The autism without intellectual disability group were kind of second, and the ID only group were third in terms of ranking of overall scores of comorbidity. But actually, when you started to look at the subscales, that's when there were kind of really big differences between the groups. So for that group with severe intellectual disability and ASD, 70% comorbidity with at least one other condition. I haven't put this in the slide, but there were a number of people who basically scored at the top of it on every scale. And they scored in the ADHD range, they scored high for depression, they scored high for anxiety. Really high rates of anxiety and depression. 50% of the group had ADHD symptoms. Nobody getting any kind of treatment for ADHD. Not really being thought about. And great, you know, these guys most of them saw the same psychiatric team because there is a specialist mental health service in Dunedin. Not really thought about the link between ADHD and autism, but really high levels of ADHD-related behaviours. So for me, this kind of really indicates that having an additional mental health problem has a really significant effect on behaviour. And we need to think about that in terms of assessments and not do what often happens and say it's all about behaviour. The other thing is that, and I'll talk a little bit about this in a second, there's a whole kind of bunch of stuff going on in the kind of neurology area that can give us some insights here. One of the other things that really stood out for me was all this group were on medication, some of them on 5 psychotropic medications, but they were still scoring really highly on all these scales. So this is another one of my song titles. Anybody know the Verve, The Drugs Don't Work? I mean, I had no opportunity to see them on or off medication. You know, there's no way of doing that. You don't want to take people off medication just to look at how they might be. It would be hugely unethical and highly dangerous. But it kind of made me think about why are we giving people absolutely shed loads of medication if they're still very agitated, very depressed, very anxious? What's the purpose of it? What's it achieving? So I'm going to come back to that one in a minute. So for the group with Asperger's syndrome or high-functioning autism, autism without intellectual disability, really high rates of anxiety, still very much higher rates of depression than the general population. I think general population is about 4 to 6% or something like that, 22%. So 4 times the general population. 9 out of the 15 were on a combination of both paroxetine and risperidone, which is kind of the treatment of choice for kind of anxiety and depression in adults with Asperger's syndrome. But it didn't really seem to be doing very much, to be honest. Again, I couldn't see them without the medication, but some people said they found it helpful. Most said they weren't sure. And this was a very intellectually capable group. Only 2 had a job. and only 2 had a long-term relationship. It was quite depressing, honestly. And they're a great bunch of guys, you know. So this is Ricky, who's one of my participants, talking about his experiences. So he's known about his diagnosis for a very long time, since he was 6. So I asked him to think about kind of what difference his diagnosis has made in his life. What was the impact of having autism on his life? I said, that's a big question, I know, but he's a very bright guy. I thought, you know, he can probably tell me this. And you can see his answer. Well, to be honest, I especially don't like people my own age. Well, Asperger's combined with a lot of anxiety really does prevent me from doing a lot of normal things. I don't have friends. I've never been in a relationship. Yeah, a lot of things people my age I haven't done. So he was just finishing his undergraduate degree at 29. It was taking him 10 years because he could only cope with doing 1 paper at a time. Yeah, very bright young guy. He has had an IQ test, 139. Yeah. But very functionally disabled by both his autism and his anxiety. So these are the themes that came out of the qualitative study. There was this really, really big overriding thing that autism prevents me doing normal things, that it has such a major impact on my life, particularly combined with anxiety, that it almost stops my life. It was really powerful, came through from everybody. This second thing about mental illness is a 24-hour-a-day thing. This came from Mr. G originally, but also other people echoed the same thing. You know, I get 8 hours a week of support. Who do I phone if I'm feeling like I want to hurt myself, or if I'm feeling kind of like, you know, I need somebody to come around and help me problem solve? Because one of the big things that came through for this group was their difficulties with problem solving. So they got themselves into a tricky situation. They couldn't figure out how to, you know, despite being very bright, couldn't figure out how to get out of it. Relationship issues with the landlord. The day I did Mr. G's interview, he'd had an argument with his flatmates. He lives with non-disabled flatmates. He has a very small amount of support a week, which he was able to tell me exactly how many minutes a week he got. But he lives with non-disabled flatmates. He'd had an argument with his flatmate. He needed to talk to somebody about kind of how to do that. He went round to the office of the organisation that supports him, but nobody was free to talk to him. So when I turned up, he was kind of stewing about what had happened and he couldn't figure out what to do about it. So I spent the kind of first part of the interview kind of thinking about doing a bit of problem solving, and then he worked out that he could talk to somebody tomorrow and that would be fine. And we got on with kind of doing the interview. But it really is, it's a 24-hour-a-day thing. You know, you can have an anxiety episode at any time of day, especially when you're living with that continuous undercurrent of anxiety. People talked about the importance of good diagnosis, both of their mental health conditions and their autism. They talked a lot about the right support when they need it, and breaking down this barrier between mental health support and disability support, and how important that was that they just had one person. I saw support workers doing amazing things. They were basically being therapists, to be quite honest, because there was nobody else working with them. Needing more time to process information and just getting overwhelmed with things was a big theme that came through. And this is one that I think is really important for those people who are psychologists working with people with autism. Most of the guys who I talked to couldn't remember the strategies they'd been taught to cope with their anxiety and depression. A couple of them said, well, I did some breathing techniques, but I don't really use them because I can't remember how to do it. Or, you know, they taught me about kind of some relaxation, but that was 10 years ago, and nobody's working with me on it anymore. So that was really important, that kind of, when you do these strategies with people, I think that kind of, we don't have a system for it, but I think a lot of the folks I talk to probably need some kind of top-up sessions on a regular basis to remind them how to use their strategies. And if we can embed that in support work, then that'd be great, by getting a better link between, you know, mental health services, treating clinicians and disability support workers. So I had a couple of other big questions that came out of the first part of my study, and I kind of started thinking about this, and I think Surrey touched on it a little bit yesterday. So does autism symptom severity or severity of intellectual disability, or a combination of both, have an effect on severity of mental health problems and type of mental health problems? And I thought, what can I do with my data that's kind of going to help me kind of work this out? And I started thinking about why people with Asperger's might have higher scores on these anxiety scales than those people with intellectual disabilities. Okay. What I found was there was a very strong link between autism symptom severity and ADHD type severity, for example. There was a really strong link between verbal language ability and anxiety. So people who could talk about anxiety scored higher on the anxiety scales. So something wrong with the scale design there. I didn't find a cumulative effect for ASD plus ID. They were independently kind of affecting different comorbid disorders. I tried doing all kinds of fancy statistical analysis to see if there was some kind of cumulative thing going on, and I couldn't find anything that was statistically meaningful. So I had a closer look at this, my sample group of people who are called complex needs. I thought maybe this can give me the answer. So I looked at, they're not an exactly matched group, but they're as close as I could get within the people I had in my sample group. So the 31 people with intellectual disability plus autism, I split into two groups depending on how they scored on the ASD-CA comorbidity assessment. And what I found was really interesting, and this kind of, I think I mentioned this earlier on. So this graph's not quite worked quite right, despite this being about the 20th version of it. But the group on the left, I'll go over here. Can you still hear me? Okay. So this is comparison group, this is complex group. So they're in pairs. My lettering's gone wonky for some reason. Comparison group, comparison group, complex group. So you can see, if you looked at my scale titles have disappeared. But you can see that the complex group scores higher basically on every scale. And what I found was that the subset of people with the most severe autism symptoms and the most severe intellectual disabilities basically scored on every scale. So there's multiple things going on, which made me think this has got to be more than just behaviour. This has got to be something neurological that's different about this group versus the comparison group. So I'm going to skip through these couple of slides. So I had a couple of individual examples, but I really want to kind of talk about this bit. So this bleak picture kind of got me thinking about what can really help? What can neuroscience offer us? What about other models of psychological treatment? Where does applied behaviour analysis or PBS fit into all this? What about quality of life? And how beneficial is medication really? And why do we keep using it? So in terms of medication, it was kind of an interesting journey. So I started thinking about why we use so much medication. And I've got a range of things I think might be at play there. I mean, I think there's the fact that often it's hard to figure out what to do. One of the things I found in residential services, a different support worker went to the appointment every time with the person. So the psychiatrist got that person's opinion of what was going on, no objective data. And the support workers were very persuasive. Oh, it's terrible at the moment. Whatever. I think that was a factor. And this is not about support workers. This is just about the way services are managed and the way we present information to our mental health professionals. So there's a big piece of work I think that we could do there in terms of how we monitor people's mental health. So in terms of neuroscience, I got really interested in neuroscience. So I kind of just did a 6-month kind of trip down a rabbit hole of neuroscience, looking at particularly amygdala and orbitofrontal loop circuits and kind of the way they interact and what the research was saying about people with autism and their frontal lobes and their amygdala. There's a whole bunch of research out there. If you want to read it, I'm not going to kind of talk a lot about it, but Cavalier and Loveland's model which talks about emotion regulation and the way that the limbic system and the orbitofrontal loop circuit works, gives a really nice picture of what might be going on for adults with autism in terms of emotion regulation, and how that problem with emotion regulation then knocks on and becomes another psychiatric disorder on top of that emotion regulation problem. So if you imagine the neurochemicals whizzing around your brain, you're going from overstimulated, understimulated, from high levels of arousal, and then you kind of, you know, noradrenaline coming in and taking you back down, so you end up depressed. So that, to me, it gives quite a compelling argument that there is something neurobiological going on for this group. So I said I wanted to kind of come back to this idea of evidence-based practice. So I started thinking about what might actually really work and be really helpful for this kind of group. So I kind of, you know, I think I mentioned, you know, in Surrey's presentation, she said there wasn't a lot out there in terms of what could work around evidence-based practice for this group in particular. So this is my kind of idea of a kind of model of practice that might work. It's theoretical. I haven't tested this. Some people might disagree with it and think it's a load of old nonsense. I don't mind, but I just wanted to put something out there and say these are some things that I think actually would be useful. They are evidence-based, but not necessarily evidence-based in this population. Okay. From neuroscience, I think there is a lot we could learn about reducing emotional arousal. And I think the old National Autistic Society spell framework is not far off the mark. They didn't have the evidence base to say that why it worked, but actually it's not a bad idea. So using low stim environments, but actually I think one of the things I learned from the neurobiology is that this group of people I think are living in almost constant fear. And if you think about them from that point of view, that it's a very kind of primal response to what's going on around them. You don't need to do a functional assessment because almost everything is a trigger. Almost everything in their life is a trigger because they're living in such a hyper-aroused state. You know, the movement of a staff close by is a trigger. So these are the kind of people who say, oh, he did that, there was no reason he did that. Actually there was. He did that because he was scared shitless. And he thought you were going to hit him or do bad things to him because that's his perception of the world. I've run out of time, but can I carry on just for 2 minutes?
Absolutely.
So what I think we need to think about is emotion regulation environments. Not just low stim, but actually the activities, the patterns, the rhythms of life being about managing arousal. So Neil Stewart from Autism New Zealand does this thing called Way to Play. And he talks about this kind of using patterns and rhythms and repetitive behaviours in a positive way. I think it's applicable for this group. I've never talked to him about this idea, but I actually think it's very similar to what you do in intensive interaction. It's kind of, you know, using repetitive movements to engage people, to manage their arousal. You can do it fast, you can bring them down, you can slow them down. So those kind of things I'm kind of thinking might be a really useful strategy. Reactive strategies that shift cognitive focus and reduce fear response. So, you know, I did the IABA, Lavinia training. Some of those counterintuitive strategies I think actually make people worse because they raise arousal level. They might stop the person doing the behaviour, but actually they're raising their overall level of arousal, so probably they're going to do another behaviour very shortly. It's a very short-term fix. I've used those strategies myself for years and years, but I think actually we need to think differently and about that whole thing about bringing people down, about slowing your movements down, about slowing the pace of life down so that people have got time to think and process information. In terms of ABA, I really think there's some things that we could think about within a positive behaviour support context. If we just focused on communication and fun and forgot about teaching people functional skills or employment skills, we could go a long way. Honestly. You know, we're talking about a group of people who's being realistic, they're very unlikely to have employment. Does it matter if they learn to clean their teeth or not? If they have great quality of life. I think I'd rather do quality of life, honestly. And I think from a therapeutic point of view, from a psychological point of view, from a neurobiology point of view, it's much more useful. I've got a couple of strategies in here that are more kind of, you know, treatment related. Behavioural relaxation training is an oldie but a goodie. I still use it on a regular basis. Bill Lindsay did heaps of work on behavioural relaxation training early on in his career. And I think it's a really useful strategy for this group, even if you only get somebody to relax for 10 seconds. 2 seconds. If they're constantly pacing up and down and constantly hyper-aroused, if you can use that kind of behavioural relaxation training strategy. If people want to know a bit more about it, Bill's early work, there's heaps of work on it, or just give me an email, come talk to me. Behavioural activation therapy is really interesting. So CBT without talking, basically. Really interesting. Andrew Jehoda and his team are doing a big trial of behavioural activation therapy at the moment with people with mild intellectual disabilities, and this is basically taking the therapy to the person instead of expecting them to come to a session. And it works by engagement. So again, you could use something like intensive interaction or a play activity as a way of engaging the person. So if somebody's really depressed and won't get out of bed, you take the activity to them. You don't try and pull them out, as I've seen happen. Okay. From positive psychology, aiming to help people flourish, build on strengths and attributes, and the things that I think are the most useful out of the positive psychology framework are about engagement and creativity. Simple things, play activities, painting, creative things. They give you a sense of well-being. And for psychiatry, right medications for the symptoms. I think I think personally, and my research would suggest we're over-medicating people. We're not getting the medication right for the symptoms that they've got. I really like what they're doing in the UK with the STOMP approach, which Sarah talked about earlier on yesterday. Cross-sector, cross-professional group, multiple people collaborating to look at the issue of over-medication. I think we could do it in New Zealand quite easily if we got people together and talked about it. So just to finish off my journey, I thought I knew a lot about autism. And I actually ended up knowing a bit about brains, which was not kind of what I set out to do. But it was quite interesting. I learnt about a bit my own as well. My own doesn't work very well a lot of the time, so kind of, From a place where I thought I had a good understanding of mental illness to a place where I'm kind of getting to grips with this idea of interaction between genes, brain architecture, childhood experience, trauma, how support services work, mindfulness, how supervision works in terms of achieving all these things for people with autism. Really thinking hard about how values-based support systems and services can use this stuff from neurobiology, neuropsychiatry. How do we make it accessible to people and easy to understand? And I kind of went from treating the DSM-4 kind of like a Bible, not so much 5 because I don't really like it, but to believing I think we've got a fundamentally flawed approach to psychiatric disorders, and I think we'll find out over the next 20 years that a lot of this is neurobiology. And the medications we have and the treatments we have will be very different. So back to just to finish off, this balance of rights, values and science, evidence-based practice. I'll come back to this. I think I've got almost the same diagram, Sarah, as you had, I think, maybe. The importance of human rights is absolute. It transcends all aspects of life in providing support or treatment. Despite this, we've got really high use of restrictive practices in New Zealand, including one of the highest rates of seclusion in the developed world. Not great, really, is it? Our strong value base, developed from a history of activism both by and on behalf of people with intellectual disabilities, guides us in our aim to help people grow and flourish in the communities and participate as actively and effectively as they're able. We don't want to lose sight of that. And in science, I'm talking about qualitative, quantitative and physical science research here. It tells us what works and hopefully why. For people with severe ASD and ID, neurobiological research can give us an understanding of behaviour beyond ABA. I very much worked from Skinner's original principles for a lot of my career, and then I started thinking maybe this is just a bit too simplistic, and there's a bit more at play here, and that's kind of where I am at the moment. Sociology research tells us about people's lives and what they value. Psychology research can tell us about what interventions or treatments might be of benefit. Bringing these together gives us some things we could focus on to improve quality of life for a group of people who frequently experience high doses of psychotropic medication, restrictive practices, often barren living environments. You know the ones I mean? Where the ornaments are up there and they've got no carpets. Yeah, we can do it different. We can do it different. I'm optimistic we can do it different. The science part gives me hope that we can do it differently and we can get it right. But unless we incorporate science, rights and values, we're not going to. And I just want to finish off by saying this is nothing to do with the medical model. This is about good support for people.